I think they were expecting
exactly.
people here. So I'll start with the introduction then. So it's my pleasure to introduce Drs. Clinton Wong and Jennifer Ju as our speakers today. And Dr. Wong is a clinical professor in the Department of Anesthesiology, Pharmacology, and Therapeutics at UBC. Dr. Wong did his undergrad at UBC, and following an internship at North York General Hospital, he did a year of anesthesia here, then practiced as a GP anesthetist in Fort Nelson for 3 years, before returning to complete his anesthesia residency. He's currently on staff at both St. Paul's Hospital and Riverview Hospital, where he's co-head of the department. He has a special interest in acute and interventional pain management. Clinton has been involved in postgraduate education since 1995, first as site coordinator for the anesthesiology residence at St. Paul's Hospital from 1995 to 2002, and then as anesthesia program director from 2002 until now. He's a Royal College accreditation surveyor. And Dr. Jennifer Ju is an alumnus of the Trinity Western University Science Program and the University of Calgary Medical School. She's currently completing her 3rd year of postgraduate training in anesthesiology at UBC. And Jenny is involved in the development of the simulator program for medical students and has a specific interest in developing the reflective component of the debriefing sessions following the students' experience in crisis management in the simulator. And Drs. Wong and Ju are going to talk to us about the portfolio experience and the UBC anesthesiology residency program from the perspective of both a program director and a resident. We're looking forward to your presentation.
Thank you for that nice introduction, Giselle. I see someone at UBC. Can you hear and see me at UBC?
Yes. Can you hear me?
Yes.
Okay.
And I don't see anybody at the other site, so I think it's just the 3 of us, 3 sites here. So I just want to start by talking a bit about how this developed. We've been running portfolios in this program for the last couple of years now, and as part of that, I meet with all the residents every 6 months roughly. And Jenny came into the office and we started talking about it. And Jenny's so passionate about the portfolio, and she says, I just love this stuff. And I got thinking, I should probably share some of this experience with others because I didn't see a lot of portfolios in other programs. And so I had a chat with Leslie Sadownik about this, and that led to a discussion with Roger Wong, and so here we are. What I'm going to do today is cover a bit about the history of how our program got here. And while some of this is specialty specific, I think a lot of things can be generalized to other areas of medicine. Going to talk a bit about what I say to the residents when I meet with them when they first start the program. What I do as a program director when I meet with the residents one-on-one. I'll talk a bit about some final words about the role portfolios, and then I'll introduce Jennifer to talk about her perspective on portfolios. I'll open up to some questions, and at the end I'll show you one example of a portfolio form. So these are the learning objectives which were pre-circulated ahead of this meeting. I hope to touch upon some of the barriers to implementation of portfolios and to hopefully provide you with some ideas of how you can overcome these barriers. So how did our program get here? So a number of years ago, the anesthesiology program directors across Canada, we meet roughly twice a year. And with CanMeds well underway, we realized there was a bit of a gap here. How do we teach and assess the 7 CanMeds roles, particularly in the non-medical expert role, which is relatively new to most programs? Dr. Joanne Tedesco, who's from Calgary at the time, was the program director, now associate dean there, shared with us her program, what she uses for this scholar role, and it was done largely in a portfolio format. And we talked about portfolios a little bit, and that portfolios historically are not used in medicine a lot. They are used in other areas, and certainly my first exposure to portfolios was from my cousin, who's a graphic artist, and he would show his portfolio with his prior work at CBS and Apple, and in fact designed the logos for both of those. And these were part of his portfolio when he would go around looking for jobs. And so medicine, it's a relatively new thing, although the idea has been around for a few years. We, as program directors, thought that we should explore this further, and so we invited Jason Frank from the Royal College to come to speak to us at the Canadian National Meeting in 2005 on how portfolios could be used in medicine. So we, as program directors, discussed this idea some more, and led by Dr. Ramona Kearney, who previous program director at the University of Alberta, and at that time she was chair of the exam committee nationally, and now associate dean at Edmonton, led this half-day workshop amongst the program directors to talk about how we could do portfolios for our specialty. So what we did was, as a result of this half-day workshop, we broke up into small groups and designed templates for the 7 CanMeds roles on how portfolios could be done for our specialty. These were further refined, and by 2006 they were available to all programs to be used, with the understanding that each program could take them back to their own program and perhaps revise them further to suit their own individual program's needs and hopefully roll them out. And by 2007, all programs, anesthesia programs in Canada, were in some fashion were using portfolios. At UBC in 2008, I brought this to the Residency Training Committee and thought about how we could implement this, and knowing that there perhaps might be some resistance to implementation, I decided to phase this in slowly. And because the collaborator portfolio was one that I was part of that small committee at the CUDA to develop, I knew that one best, so I decided to roll this out in a staged manner, starting with a collaborator portfolio, starting with just the PGY1s, so that more senior residents were grandfathered from this. And when I introduce when we meet with the incoming applicants to CARMS, I say this is happening so that they're not surprised. So in 2008, we started with the PGY1s, just with one CanMeds role, and it was a collaborator role. Each year, we added 2 more portfolios, and so now currently we have not only the collaborator, but manager and health advocate, and the plan is at tonight's RTC meeting, I'll introduce 2 more, the scholar and professional. And so eventually, over time, the aim is to have all 7 roles for all 5 PGY years. So what I do is I meet with the new PGY1s sometime during their PGY 1 year during the academic day, and I introduce the concept of portfolios to them, and I'll show you the PowerPoint as part of this presentation later on. I then meet with each resident when I meet with them one-on-one, and I talk about their portfolio and ask them to show me, and I emphasize the reflective component of the portfolio. I also emphasize that the portfolio is a personal thing. It belongs to the resident and not part of the program. Therefore, their portfolio doesn't go into the resident file. Instead, I keep notes on the quality of their portfolios in my own notes in the residence file. So what I will show you next is what I actually show the PGY1s in their PGY 1 year, and it's basically an abbreviated presentation that Dr. Kearney provided to all of us at the national level, and I have her permission to share this with residents and with faculty. So I acknowledge this is largely her doing here. So she has a Masters of Education, which is very helpful in developing this sort of thing. This is the objectives of this session to the PGY1s, and particularly to document learning and to reflect upon the learning experiences. And this is the traditional learning cycle in residency. You have a set of learning objectives which should lead to development of a curriculum, which then leads to the learning experience and the assessment of whether or not the objectives were met. So why do we need to assess learning? our goal is to make sure that our trainees by the end of the residency are competent. And the traditional methods of assessment include the written exam, both multiple choice and short answer question, and the oral exam. One of the things I focus upon when I meet with the residents is that while our goal is to make sure that they're competent by the end of their 5 years of residency training, they're not yet expert. And to become an expert requires time, somewhere between 2 to 5 years, depending on the individual. But time alone isn't enough to become an expert. One needs to reflect upon your practice during those important years to help you develop into an expert, and not just the medical expert role, but all 7 CanMeds roles. So I show this to the residents. I don't have to show this audience the CanMeds roles, but obviously the medical expert role is the central role, but the other 6 are very important as well. And that's where we run into some problems, is the traditional assessments have a very limited role in these other 6 non-medical expert CanMeds roles. And there's some challenges in trying to not only teach, but in particular assess these other 6 roles. And also to stress the importance, as I indicated earlier, that lifelong learning must occur in these other areas as well. So how do we do this? How do we get around this problem? As we know, the final and training evaluation report not only covers the medical expert role, but also the other 6 roles. And this is a challenge for most programs, I would suspect. This is the traditional assessment methods that we have here are rotation assessments, or in-training evaluation reports, or ITERs, are written and oral exams that we use. And this is what probably most programs use, not only in anesthesia, but other residency programs. At the Royal College, at least in anesthesiology, these are traditional methods of assessment. And I'm sorry for this slide. It's a bit busy, and it's actually, I have trouble seeing it from here, but across the top you have the 7 CanMeds roles, and across the left-hand column down the side there you have the various methods of assessment. And so the first 3, written exam, oral exam, ITERs, the plus signs refers to its utility in the different 7 CanMeds roles. And the written exam and oral exam are good at the medical expert role, but they're difficult with the other roles. The ITERs, in theory, are good for many of the roles, but I'll talk a bit about its limitations in practice. OSCEs and 360 evaluations are also good in some areas. And second to the bottom is the role of portfolios. And as you can see, it has good utility in many of the non-medical expert roles. And the bottom is this role of simulation in assessment. So based on this, it was felt that some of the preferred assessment tools would be the training evaluation, 360 assessment, and portfolios. Some of the advantages of in-training evaluation reports consists of a list of scales, meets expectations, below expectations, above, etc., based on actual observation of performance in the clinical arena, and it's fairly efficient to use. And the evaluator, usually the faculty member, can use multiple sources of information. However, there are a number of disadvantages to the in-training evaluation report, which many of you already know. It's difficult to assess certain areas. It's prone to what's called the halo effect, and probably many of you have seen the evaluation reports with a straight line down through meets expectations through all the different areas. There's a bias to not providing negative evaluations. And evaluators tend to use a fairly narrow range of the full spectrum of options, so you don't tend to see below expectations or the top level very much. Most people fall in the middle portion of this graph. So what is a portfolio? And here we have a couple of definitions. And the one I'd like to focus on is the reflection component. And we'll speak more about the reflective component. But it is a way of documenting learning in different areas. And certainly some more definitions of reflection. And I think the reflection is the key part of this, because without the reflective component, a portfolio becomes simply a logbook of experiences. And while we do have a resident logbook in our training program, it serves a different purpose than the portfolio. The logbook is, in my mind, good for the medical expert role to document how many cases of what kind of cases the resident's done, without necessarily without the reflective component. So this is what portfolios are to consist of, and it has a number of advantages. You can look at different areas of the CanMeds roles, you can identify deficiencies, you can tailor it to the individual residents, and you can see how they progress over time. There are some disadvantages to portfolios. And the B stands for barriers, and these are all barriers. It is time-consuming for residents, so it does require some commitment from the residents to do. It's virtually impossible to standardize, how do you compare residents' performance in the different CanMeds roles, and it's hard to quantitate. I would suggest to you this is more of a qualitative thing. And then for the person, in this case it's me as program director, to review the portfolio with individual residents. This also takes time. And it's not great for, does someone pass the, for example, collaborator role, and it's hard to provide summative evaluations. So some more key points. It's hard to really say, is the portfolio accurate? It depends on the resident's input, and it's very hard for me to verify how accurate the records are. But I'm not sure if that's all that important. But it does require the resident to provide some initiative to make this all work. I will, at the end of this talk, show you what we use for our collaborator role for the portfolio. But basically it consists of both tick boxes where they tick off didactic sessions they've attended, some reference articles related to this particular CanMeds roles, and then to provide some specific examples from their own clinical or non-clinical environment in this CanMeds roles, basically as a narrative, and to reflect upon both components. So what do I do when I meet with the residents to motivate them to do this? I tell them that this was passed by the Residency Training Committee as mandatory. I also tell them that every other program nationally is doing this for their residents, and more importantly, to improve in their performance and their ability in the non-medical expert roles. I also then go on to tell them about the fact that when you finish your program here, you will be competent, but you're not going to be an expert yet. It's going to take time to be an expert, but time alone is not sufficient. You have to have time plus reflection. Otherwise, without that, you will practice the same way you learned medicine following residency for the next 30-odd years and not improve. And I think most residents would agree that's not the way they want to practice for the next 30 years. So in order to make sure that happens, the program needs to promote this idea of reflection during residency so that we're confident that it will continue post-residency. I also go on to say that more and more we see, or at least I see, applications from physicians from other parts of the world who include in their application not only their CV and logbook, but also their portfolio. And that when applying for positions, often, at least in anesthesia, I've noticed that departments often assume the medical expert role is there, but the problem that sometimes becomes a problem is how are they in terms of their other roles, in terms of communication, collaboration, professionalism. These often become the make or breaker in terms of whether or not a person is offered a position. So, and sometimes I find residents don't always see that part of it. They focus on the medical expert role, and I try to emphasize the non-medical expert roles. So the portfolios can be used to demonstrate their abilities and document learning in these non-medical expert roles. Some of the advantages of portfolios, we've covered some of this already. It's to document learning and to document reflection on the different roles, and to emphasize that lifelong learning is emphasized, which is really part of the CanMed Scholar role, I believe, for all programs. So this is the learning experience now with reflection as part of it. So you have some experience, usually a clinical experience at the top. There's some reflection upon that experience. As a result of that reflection, the resident learns something from that and then applies that to their future experiences, which then leads to further reflection. So this is the circle that I like to see with residents as they go through the program. And again, it becomes more meaningful to the individual resident when they can actually remember experiences that they can reflect upon. Looking around the world, we see that portfolios are used more commonly than in Canada. So in the UK, this is now almost 10 years ago, but in medical schools, some 40% of medical schools in the UK use some sort of portfolios. And so I think we're a little slower in Canada, but I sort of see this changing. And perhaps because it's a newer concept in Canada, it's a little slow in taking off. From the resident's perspective, they need to understand why we're doing portfolios, what the criteria are. And the criteria in my mind are fairly loose. I like to see that reflection is going on, that there's some improvement over time. It does take time. It requires commitment from the residents. And residents can't cram for this the night before a meeting. Oh, I better do this before my meeting with Dr. Wong tomorrow. So it's got to be done, more consistently. I tell the residents, read the 2 reference articles and then complete 1 narrative. And for the collaborator role, I like to focus on a conflict. And often residents work in team situations, and as a result of team experiences, there's often a conflict involved. And so I like them to describe what the team consisted of, the different people, their roles, what your role was, and what the nature of the conflict was, what the outcome was, and the reflective component. What did you learn from this? What would you do differently next time? So this is basically what I tell the residents at in their PGY 1 year. What do I do when I meet with them individually, one-on-one, every 6 months roughly? I go through a number of things, but one of the things I go through is show me your portfolio. And they're expected to bring in their portfolio and show it to me. I focus on the narrative components, and I find this often a fruitful area for discussion. You learn about things that are very interesting about what residents go through, particularly because they focus on challenging situations and challenging experiences. And I ask for the reflective component. And in my experience, this is where residents often tend to be a little bit thin on. And
your conference is scheduled to end in 2 minutes.
I don't know if I can finish in 2 minutes. Okay. I asked them questions. What did you learn from this experience? What did you do well, and what would you do differently next time? And as a result of that, I make suggestions for our next meeting. And if I sense there was somewhat less than full compliance with this, I reinforce the message I indicated to them earlier on, the importance of portfolios. I'm going to finish off with a few final words. This is for the professional role, and this is from a review article in the New England Journal from a couple of years ago, and it talks about the importance of reflection on developing professionalism and discussion as well. I've been on both as a surveyor and a surveyee through Royal College accreditation, and as part of that, you do the pre-survey document or questionnaire, and part of the pre-survey questionnaire includes this document. How do you assess your residents? And it's supposed to tell you in each PGY year how you document evaluation, and most programs use the in-training evaluation report and some written and oral exams, but perhaps little else. And this has been my experience for most programs. And what I'd like to hope to impress upon is that next time you go through for your own program, hopefully portfolios will be included as part of your assessment of your residents, particularly in the non-Can Meds roles. So at this time, I'd like to introduce Dr. Jennifer Yeo. She's, as mentioned by earlier by Giselle, she's a PGY3 resident, and she's been doing this for a few years now, and she's passionate about this, and I think I wish all my residents were as passionate about portfolios as Jennifer is. And so Jenny's just going to talk about what this means to her as a resident, and at the end I'm going to open it up to questions and then show you a sample portfolio. Jenny?
We're still on the air. Yep. Okay. Hi there, my name is Jenny. I thought that the best way to share my passion for the portfolio project would be to give an example, a concrete example of one of my entries in the collaborator portfolio. So I guess what's important to note is that this is one of the reflections in one of the roles. So this is the collaborator role, which is one of 7. This was the role that was introduced the earliest for us. So we've been doing this role since PGY 1. So I've now done 6 entries like this in the collaborator portfolio, and then also some entries in the other 2 that have been introduced so far. So this one comes from my PGY 2 year, and I think if you look for when you're listening to look for the effect that knowing that I need to do a portfolio entry has on me during the experience, because I think one of the points that was made by Dr. Wong was that having to do the portfolio project helps us to plan our learning activities in residency, and it actually helps us to react in certain ways in given situations. So what I'll do is summarize the first part of this and then read the second half of it. So this is my PGY 2 year, quite a fresh anesthesia resident doing my ICU rotation at St. Paul's, and I'm taking care of a gentleman who has tried to commit suicide by taking a polypharmacy overdose. So he lives on the downtown east side. He's kind of one of these frequent flyers, really well known to all of the services at St. Paul's. And I intubated him when he came in with his overdose, and initiated the renal replacement therapy. And now he's woken up, and extubated him yesterday. Got a psych consult this morning, and the resident came by and said, you know what, he's doing well. He's turned a new leaf. He's going to go home and stay with his sister. I think he's ready to go. Doesn't need to be admitted to psych. Thank you for your consult. So then I go to see him the next morning, and he's got tears streaking down his face, and I address him tenderly, and I say, what's going on? And he says, well, my sister has now said I'm not welcome at her home, and I can't go there. I'm going to go home, and I'm going to take 3 times as much medication as I took last time. And I'm like, oh my goodness, in my little PGY2 anesthesia mind, like, this man is suicidal. He's got a plan, and I'm pretty convinced that he's going to go home and commit suicide. So what do? I write a note in the chart that says that I'm concerned that he's going to go home and commit suicide. And so I page the psych resident who was involved, and she's not available that day, so I page the attending psychiatrist, and she kindly says that she's going to come by and do a reassessment later on this afternoon. So I'll read to you what happened after that. So attempting to finish rounds at the end of the day at around 6 o'clock, I stood with a group of my peers and allied healthcare workers as we discussed another of the newly admitted patients. A woman I did not know briskly approached the group holding my patient's chart and demanded in a loud voice to know which one of us was Dr. Yo. Surprised by the intensity in her disposition, I stepped out of the circle quickly and engaged her, assuming that there was some sort of emergency. Without introducing herself, the woman barked, "Look, I'm going to tell you a few things about patients with personality disorders because clearly your training until now has not covered that topic." I was like, taken aback, I felt my face flush. As you guys can see, I flush kind of very, very easily. And my peers tried not to stare, of course, at the spectacle. She continued, "This patient put on a perfect little act for you this morning because he knew that you would naively buy his lines and keep him in, feeding and coddling him indefinitely. He knows the system and he's working it. This note you wrote has tied my hands. If he goes home and takes a bunch of pills again, which he will, and you've documented that he is at high risk of death by suicide, as you have, then if I send him home, then I am liable for his death and I will get sued by his family, not you." If we kept every personality disordered downtown East Side drug user who attempted suicide in the hospital until they were no longer a suicide risk, there would be no room for anybody else. Now, I have never been yelled at in a professional setting before. Initially, I was surprised, embarrassed, and a little confused. When I realized that I must be speaking to the psychiatrist on call, I became a little more oriented. The next feeling I experienced was something like the feeling one gets on their way to a code blue situation. Exhilaration. This was surprising, but the thought in my head, as I was half hearing what the attending psychiatrist was barking at me, was, "This is it. This is a real conflict. Okay, I've practiced dealing with these before. I've talked about all of these principles. Now it's time to employ them." The following may be hard to believe, but during the rant, I had time to apply 2 conflict resolution principles I had learned in seminars and courses and from reading in the past. First, I thought about my body language. My arms were folded across my chest, so I dropped them to a neutral position at my sides. My forehead was knit into a frown, so I relaxed my face and made direct eye contact with the psychiatrist. My stomach was in a knot, and my posture was stooped as if I was bracing for a blow to the abdomen. I straightened, relaxed my shoulders, and took a deep breath. Just as promised by the instructors of conflict resolution courses, these simple actions had a relaxing effect, and I found the flush disappeared from my face. As a result, I was able to employ the second principle, which was reframing the interaction with minimal effort. Instead of focusing on the feeling of being attacked, I could focus on the real issue at hand, which was the optimal care of our patient. Suddenly, instead of adversaries, we were partners, albeit with different perspectives. The next essential step in conflict resolution is denying the impulse to take a defensive stance and instead taking responsibility for one's own contributions to the conflict. As the psychiatrist stormed away, I took a moment to collect my thoughts, then I followed her to the charting area. I apologized for the difficulty that I had caused her and admitted that I did not have much experience dealing with this type of patient. Next, I asked to hear more about her perspective. Her tone softened significantly, and she spoke with fatigue in her voice about the lack of sufficient facilities and resources to deal with the complex problems of this demographic. I asked how I should have handled the situation in her view. She told me that if she had been in my place, she would have been worried about our patient too. But knowing the system as she does now, she sees that the principle of justice and the need to appropriately triage patients is often the more important factor in deciding who to admit and who to discharge. She told me to try to speak directly to the resident or psychiatrist to develop a bigger picture of the situation before documenting an opinion on a topic that I am not an expert in. She completed her note, and as we walked past my ICU attending physician and my colleagues, she thanked me for my work and apologized for her aggressive approach. She left the department, and I turned to a fellow anesthesia resident with a smile, and he said, "Good job, you'll have to put that one in the portfolio." On reflection, it is clear that some things were done well. I am pleased with the natural way I was able to quickly incorporate principles that I had learned about conflict management. I think a potentially explosive and hurtful situation was diffused as quickly as could be expected. The rapid reconciliation between the psychiatrist and myself facilitated the best possible patient care and gave me the opportunity to develop a bigger picture of the challenges facing my colleagues and the healthcare system at St. Paul's. On the other hand, it is clear that the manner in which the psychiatrist initially approached me was inappropriate. She probably should have asked for a private discussion with me in order to express her feelings or control her emotions as she spoke to me in front of my colleagues, so as not to interfere with the functioning of the team taking care of the patient. In the end, the way the conflict played out, I think, made her realize the error in her approach, and she will hopefully be more collaborative next time. I must admit, however, that the entire conflict could have been easily avoided if I had only called and spoken directly to the psychiatrist or the resident on the phone or in person before writing a note with a weighty opinion concerning a topic that I have only personally dealt with infrequently. These interactions are vitally important to patient care and smooth team functioning, and I learned two very important lessons. Firstly, it is essential to try to predict the ramifications of my words and actions for my team members, and secondly, apparently a conversation is worth more than 1,000 chart notes. Finally, it is important to strike a balance between assertively protecting your right to be treated respectfully in the workplace and maintaining a humble approach to each new interaction concerning patient care. I believe that the best first steps in this career-long endeavor are to consistently treat others with respect, to strive to model humble collaborative behavior, and to quickly take responsibility for my part in any conflict. This way I can encourage those around me who struggle with conflict prevention or resolution and gently hold them to the same standards over time. So that's one of my entries. And for me, I think knowing that I had to do this kind of a reflective, being trained, I guess, first in collaborator skills, and then knowing that I had to do this kind of a reflection helped me to just be aware that these situations are going to arise, and I have a toolbox to deal with these situations, and I'm going to make mistakes too. So that's expected. This is par for the course, and then it's kind of what you do with them that matters. And so this was a very valuable experience, and I think every single one of my reflections has kind of had a similar effect for me. And I would say that the biggest barrier that my colleagues talk about is the amount of time that it takes to do these, because this probably took me 2 hours to write out, and when you think twice a year, 2 hours times 7 different roles, it adds up. I mean, it's not a crazy amount of time, but for somebody who doesn't necessarily see the benefit as much, it's quite a bit. But I would argue that actually it's the fact that it does take time that makes it even more important that we have a formalized, necessary component to our education, because otherwise most of us are going to miss out on this. I do love to journal, but for sure I wouldn't do this much journaling if I didn't have to put a portfolio project together. So for me, it's really validated this bent that I have towards doing this kind of reflective stuff. So I really appreciate all of the effort that you guys have put into, especially to Dr. Wong. It's really good.
So I think you can see why when I hear stories like that, it's very, I don't know, it's hard not to sit back and think, wow, this is really powerful as a tool. So I hear this, Jenny's exceptional in the way she's done it, and so I think she's almost like a gold standard in terms of how this sort of thing can be used. At this point, I want to open the floor to questions, and then I'll show you a sample portfolio at the end. So any questions from, I guess, UBC, first of all?
Yeah, go.
Hi, can you hear us?
Yes.
Yeah, it's Carol Ann Cornea, and I just have a quick question for Jenny to ask her if she said in her brief comments, she said that she really likes to journal and has done it in the past, and I'm curious if she has a background in narrative or what your degree was going into medicine, or is this just a casual interest in journaling, or did you do a lot of it?
Yeah, can you hear me there? I think it's on.
Yeah, I can hear you.
No, I did a biology degree at Trinity Western University, which is a broad kind of liberal arts education. I don't have any formal training, and I actually didn't even do English at a university level because I got credit for it from my high school IB course. So no, it's just very casual.
Okay, thanks.
Any other questions from UBC? Oh, from Victoria, I guess, Giselle.
Hi, first of all, I wanted to say I really enjoyed the presentation. And I don't know if everybody knows, but the presentations are recorded and will go on the faculty development website so that people who weren't able to be here today can access them. And I wanted to ask that when the people from Diamond Center talk or ask questions in a minute, if they could press on their mics so that everybody can hear. So I had a couple of questions. First one was whether you've ever been asked by other departments or programs to share this or help them with this. And the second was you alluded to the fact, Clinton, about the use of portfolios possibly in continuing professional development for revalidation. And I'm aware that that has happened in England. And I'm wondering what your opinion would be for them. Because I mean, I hear Jenny say that it's a lot of work. Do you think practicing doctors would do it? And I guess maybe from Jenny's perspective, does doing this as a resident make you think, more likely to be willing to do that when you're a practicing physician?
So maybe the second question first.
Sure. Yeah, I think it does. It makes me more likely to continue to do this in a formal manner after, because I mean, it's a very strong message that we're getting, that this is important and this is how you do your deep learning. This is how you change on a professional level. So yeah, I think so. It's difficult for me to speak for my colleagues if they're going to do it as a kind of jumping through a hoop and then stop. But I think for a significant portion of us, it will make this kind of a thing more likely to continue.
I'm sorry, I didn't quite catch the first part of the question, Giselle.
Well, the first part of the question was related to how you thought this might play out in CME or CPD, whether people would be willing to do this. And also whether,
for CME, I see. That's a good question.
Would you do it?
I think if I had started it during residency, I probably would continue. You sort of do this informally. I think most of us in here who are sort of my vintage probably did this subconsciously, perhaps. You have a difficult experience, say, in the clinical arena, and you think back upon that, and you think, gee, I didn't feel very good about that. What did I learn from this? And I think a lot of that happens in your first few years of development anyways. And the difference being that you don't write it down, you don't talk to others about it, or you may talk to others about it, but I think largely it's your own internal thoughts about these experiences that leads to a change in behavior. So having it in the portfolio fashion documents this sort of activity, which many of us sort of do subconsciously. I don't know if that answers your question, but I think if if this becomes a regular thing in residency programs, and I think it's easier to implement at the CME level. The barriers that I sense from some residents on doing this is that, this is just an exercise. I don't really want to do this, but I'm told I have to do this. I think that might change over time with a shift in culture, but that may take some years.
Okay, thank you. And have you been asked to share this with other departments or programs at UBC? Or?
Well, certainly at the national anesthesia level, when we meet, we share these things with each other to learn from each other what works, what doesn't work so well in our own programs, so that we can sort of learn from that. But beyond anesthesia, this is the first time I've gone outside of to other areas to share this experience.
Thank you.
So questions from here.
So Clinton, can residents kind of create their own halo effect? They come to you each year with these portfolio entries that actually demonstrate what a wonderful job they're doing in their residency. I mean, it would be a natural bias to bring to you good work. And the same way, would a portfolio be discoverable? I've now had a conflict situation at work, and now someone is looking for that record, and they'd like to see what my inner thoughts were and how I did badly, and clearly that provides good evidence that I didn't meet the standard at some point.
So on the first question, halo effect from residents, part of my meeting with them is to provide that outside look at their performance. So if they come to me and say, you know, I did really well on this and I don't really have anything I wouldn't do it any differently. And I'm thinking to myself, well, I'm not sure if I would have done it that way. And I sort of ask a few leading questions as to, well, what about this? Did you think about that? And so that gets them thinking about, you know, perhaps there are other ways that this could have been handled. And I think I sort of open up perhaps their insight a little bit on their performance and suggest at the next meeting that perhaps you could consider implementing some of these things that we've talked about. So I think over time, you know, and I keep notes about very, very general notes about that sort of thing in the residence file. I don't put down any details. So on the question about being discoverable, you know, I'm not sure if residence files are discoverable, but what's in that is sort of my impressions on their performance in the different CanMeds roles and without the details. And that's why I've purposely tried to leave the details out of the residence files. Now, whether the portfolios that belongs to the residents can be discoverable, I don't know. I mean, is your diary at home discoverable? So, question from Brian Warner.
This is more of a comment than a question, and I guess it's, you know, because I am one of those people who's been in practice for 30 years, and I've learned some of the things that Jennifer learned very early on, probably about 15 years into practice, and I can tell you that there are a great number of screaming matches that occurred before I started to figure out that this kind of behavior wasn't productive, and it wasn't really doing me any good, and it really wasn't making me feel any better, and it clearly wasn't to the benefit of the patient. The model under which I learned was the model of mentorship, where you followed the pattern of your older colleagues, and of course the behavior I learned was largely based on the kind of behavior that, although not acceptable at that time, was widely present. And I just am very impressed with how far Jennifer's already come in terms of her understanding of how to collaborate with people, how to interact with people, and how to reflect. See, I'm picking up the jargon right away. How to reflect on her own involvement in the process, and how she herself can make these events less stressful and less potentially damaging in the future. So I know Jennifer's an exceptional resident, and I'm very pleased that we have her in our program. But I do think this is valuable to all our trainees, and I'm very pleased that this is now part of medical education, at least in anesthesiology in Canada.
Sorry.
So, Clinton, I have a couple of interested in your comments, because there seems to me quite a bit of background work, you know, before introducing this assessment tool. I mean, part of it is the fact that the residents have training in the CanMed competencies, so when they're put in a difficult situation, they have some tools to reflect upon that situation and say, I should have done this or I should have done that. Otherwise, you're sort of letting them just go into conflict and then reflect on it without any idea of what to do. So I'm sort of interested in how, you know, what your perspective as well as the national perspective of how you build that in to your programs. Is that considered sort of a precursor to this assessment tool?
I don't know if it's a precursor. I think it needs to be done. So, you know, with the accreditation, you have to not only teach the roles, but you have to assess the roles. And I see this more in the assessment end of things. You need to have the teaching part to make this work. And when do you introduce the teaching part? I don't think you need to have the teaching part first. I think they can be done in parallel. So that you know, some of these didactic sessions may not occur before the difficult situation that the resident gets put into. But hopefully, when the resident goes to a didactic session about, say, conflict resolution, and had one some months ago, and they reflect upon that experience to think, you know, if I had known that before, maybe I would have done things differently. So perhaps the didactic session imparts a more meaningful thing to them.
Right. And the other thing is, obviously, you're an experienced program director who's dealt with these difficult situations before, and I just wonder how comfortable a new program director would be in counseling residents or discussing their portfolios with them.
So I think on that point, I don't think it necessarily has to be the program director to do this sort of thing. I think you need a champion for portfolios in a program who may or may not be the program director. In this case, I happen to be the person who brought it into our program, and therefore I kind of see myself as that champion, but I don't necessarily think that it has to be the same person, and partly because it does take some time and commitment. So I'd rather see a champion who has that time commitment and to do this, and so it doesn't necessarily have to be. It could be a delegated task to someone.
And in fact, in that way, it sort of removes in some ways, it's like an ombudsman.
Yes.
You remove the conflict of assessing performance to this being really purely a formative assessment tool.
Exactly.
Yeah.
Thanks, Clinton. I was wondering about what kind of guidelines you give to residents, and Jenny, you might be able to answer this well, in terms of what to write. You have 7 CAMEDS roles that you're doing this around, and it seems clear that for the collaborative role, there must have been some sort of guideline to say, reflect on a situation that you'd been in that involved X, Y, Z. Like what kind of instruction or questions do you pose that help the residents know what to write? And
so I'll just answer briefly, and then maybe Jenny can comment. For the collaborator role, it was felt that conflict situations, because they sort of illustrate or there are situations which illustrate the strongest need for conflict for collaborator roles. I thought those would be very useful. And while conflicts don't always occur, I think if you go through residency, they have to occur at some point. And it's often attached with a lot of strong emotions, and often it's those situations that you remember or you learn the most. And so I purposely, when I designed the collaborator portfolio, I purposely said, let's focus on conflict situations and use that as the portfolio model for collaborator. So that I tell residents to pick a conflict that you're in, either in the clinical or it may not be a clinical situation. It could be a conflict over call schedules or academic day issues or something related, or research issues. So it need not be in the clinical context, but the clinical context seems to be the most common area for conflicts.
But can you give us some examples in some of the other roles of what questions you then pose to the residents to?
Well, the other portfolios I'm less familiar with. I sort of look at them and I sort of I asked them to comment on examples of, say, a communication one. What was the issue about? Maybe there was a miscommunication, and how did that evolve, and what did you learn, and what would you do differently next time? So that would be one example for the communication portfolio, which hasn't been approved yet by our RTC, but that's hopefully tonight's meeting will approve that.
So I think Dr. Wong will show you the collaborator portfolio in a minute here, and there's actually very clear wording on that one. On one hand, you have like the scoring system and the boxes that you must check off, and you have to get, I think, 3 points per semester. There's some scoring system to give you a kind of an outline of what you should be doing every 6 months or so. But then underneath, there's a very specific thing that says, give an example of a situation, say who were the people involved, what was the situation. So it's for that one, it's very specific, kind of outline this, and then emphasizing the reflective component. Yeah, see, this is funny. This is the one we've been focusing on. So the health advocate role is one that's been approved. So one of my things that is in my portfolio for that role is a pamphlet that I made for patients to tell them about the role of epopoietin in preparing for surgery to get their hemoglobin up. So it's health advocacy because it's, for patients. So we're kind of advocating for this group of patients who's coming for surgery. So I made this thing up, but then I also wrote a reflection on the process of making that pamphlet. So these are what the challenges were. This is what I found, this is what I think went well about it. If I had to make this pamphlet again, maybe I would do this or that differently. And then what I did was interviewed some patients who had read the pamphlet and got some feedback from them, and then kind of put that in my reflection. So
Sorry. Leslie, we're not, I think you're putting something up that you're looking at DHCC, is that correct?
No, I haven't been able to put it up. I'm trying to.
Oh, okay.
There's some technical problems.
It's a blank screen right now. I can't seem to connect the laptop. We'll give you a thumbs up if we see it.
I'll answer that question with the manager role. I tell residents that one of the things that new residents, when they finish the program, have the most challenges when they first arrive on call at night, and both David and I were on call at night, so we'll probably we can appreciate this. You show up at 6 o'clock at night and you've got a slate full of emergency cases to do. You've got all these elective cases running late. You've got all these nurses on overtime. You've got a lot of surgeons waiting to get their emergency cases done, and they're saying, when can I get my case done? You've got PAR backlogged with ICU patients, and they can't take any more patients. And you're thrown into this challenging situation from a manager role. And I tell residents, you're going to face this when you finish. So we need to help you learn how to manage a limited resource such as OR nurses and PAR nurses and your own time to effectively get through the situation. And while I don't expect residents to be able to do that during the residency, I ask them to learn components of that role during their training. So, I give them responsibilities such as looking after the PAR, and asked that they learn the manager role and reflect upon that experience so that by the end of the residency, hopefully they'll be able to put it together and be able to face that situation more effectively. So that's what I tell residents in the manager role. I don't know if that answers your question. Any other questions? I think we're running close to the 1 o'clock timeline here. So,
can I ask a quick question from UBC? What actual program are you using to present this portfolio? Is it a simple Word document that they're directed to, or are you using some other software?
The portfolio form is a Word document that I send to them electronically. They can print it out, and then they simply write on it. And some of them keep them in a binder with 7 folders. Some keep it electronic and enter everything electronic, and they bring in their laptop and show me what they have on their laptop. So I've seen both ways.
Thank you.
Yeah. Oh, I was going to show you this Word document on screen here. So can you all see that? So this is the instructions are at the very top corner. It's a little hard to read, but just the simple instructions to the residents. Early on, I have revised this form a little bit, Jenny, but early on we had point systems. If you do this, you get so many points. But I've tended to de-emphasize the points and say, just put a tick box behind the different activities. So there's some didactic sessions, some reference articles on this collaborator role. Participation in workshops, and we use simulation in anesthesia, so often there's a conflict in the simulator that they're put into. And then the key part of this is a formal narrative of their experience. I also, I don't know if David Parsons would be happy with this, but I also include the Royal College CanMed's goals and also an excerpt from their fighter on this role, what we're expected to fill out at the end of their training on this role, so that they know what we're supposed to do at the end of their training. So hopefully this gives them a target so that I hopefully will be able to fill out either generally meets or sometimes exceeds or consistently exceeds in those 2 different areas for their fighter.
Clinton, it's kind of interesting. We have always kind of held the fighter back so no one can see it until the last second when you're asked to sign it, right? And at the specialty committee, we've never had any discussion about revealing the fighter document to residents. I can't imagine why we wouldn't, but we've just never talked about it.
Well, it's interesting you say that because I've been told that, maybe this is off the record, but what I have here is a pirated version of the fighter electronic that someone who will remain unnamed across the country has given to me, because we're not supposed to have an electronic version of the fighter. It's only a paper version that we're supposed to have. So,
I'm sure Dr. Spatafor will give it to everyone.
No. Any other questions?
I have a comment and a question. I'm Luke Chen. I'm joining the clinical hematology staff next month, and I've been thinking about trying to introduce portfolios into the hematology training program for a little while now. So maybe I'll be the first, the other division or department to ask you for advice. But I really enjoyed the presentation today. I thought it highlighted two of the difficulties that I've had with CanMeds over the past few years. One is context. When I was in internal medicine in Ottawa, they used to take us out of the wards one half day every couple of months and go downtown, and we'd have a workshop on some CanMeds role completely out of context, and everyone would completely forget about it as soon as, you know, whatever topic it was finished for the day. But you know, Jennifer, your sharing brought out the fact that when we combine this with actual clinical medicine, then it becomes much more powerful. And the second is that I think there's this assumption that most of the non-medical expert roles are being learned in the hidden curriculum, and that's a bad thing. And it's not necessarily a bad thing. I think a lot of things are going on in the hidden curriculum, like people are learning about health advocacy at tumor board or, you know, whatever, or by watching their preceptors manage the OR and the PAR. And I think we just need to bring it into the overt curriculum, and I think portfolios allow us to do that. So thank you for demonstrating that that can be done. My question, though, is that I think in undergrad medical education, we're very aware that curriculum design is a zero-sum game. You can't add something without taking something away. And I think we're a little bit less careful about that in postgraduate curriculum development. We have the temptation to just keep adding stuff. And when I think about 2 hours for an entry for 7 roles is 14 hours every 6 months. It's a pretty good chunk of time. And I wonder, do you set aside protected time, like, you know, a half day for portfolio development or something like that? Or do you have any proposals for where that time comes from?
That's a very good question. We don't do that in our program. I'm not sure where Jenny finds the time to do it. I'm not sure, like, it's like saying, are we going to set aside 2 hours during academic day for residents to sit down at a desk and do their portfolios? To me, that's kind of like how I went through grade 5. And I'm not sure if that's the right model in adult education. I think, I don't have a good answer to that, basically. I think I would like to think that, at least in anesthesia training, we're not so demanding that time becomes a major issue. And if anything, there has been criticism that perhaps residents don't spend enough time doing clinical work. I've heard that argument before from some circles. Names will remain unnamed. But I think I see this as a very worthwhile endeavor that is worth the time. Should we as a program provide that time? That's a good question, and we've had that discussion about other areas that we provide in the study time. Should programs provide study time for residents to prepare for exams? And that's certainly a controversial topic in itself as well. So I don't have a good answer to that question.
I could just comment. I think we're quite blessed in our program because we have a full academic day. I think internal medicine, you guys have a half day.
Yeah, I think, like in core internal medicine, they have a half day. For the subspecialties, it's quite variable. Some don't even have a half day. I guess my point is that there's a cost, and if we don't count the cost, somebody else will for us eventually.
Yeah, for sure. I think, in my mind, our academic days often end earlier than a regular clinical day. Mm-hmm. So I think of the extra 2 hours between 3 and 5 in the afternoon of our academic days as kind of like, well, it's a bit of bonus time, and we also have pre and post call days. So there's quite a bit of flex time in our schedule already. So right. I think that we do have research stuff that we have to do as well, and you're right, it adds up over time, and we do have to be sensitive to that. But of course, the clinical time is already being squeezed, so it might be difficult to take away from that.
Right. I think that's it for questions. I want to thank you all for coming to listen to both Jenny and I for this talk.
Thank you.
Thank you so much, Jenny. That's great. You worked very well.
It's always a bit embarrassing to share your journal.
Oh, I know. It's like showing your diary, right? But I think it sends a stronger
It does.
message.
It's much stronger. In fact, I think you